So thank you, and it's really great to be able, and a real privilege to be able to present to you some information about how we treat brain metastases, which is a very important component of the care for patients. So I am not a surgeon, as you can guess by the radiation oncology appointment, but I'm going to talk a little bit about surgery in this talk. And any of the surgeons, and I know there are no neurosurgeons here, so I'm pretty safe, but any of the surgeons in here, if I say something wrong, just don't let anyone know. So when we talk about treating brain metastases, we really have many options, and that's something I want to make sure is relayed to you, that there really are different ways to go, different ways to approach this. And all of the treatments are really multidisciplinary. They involve collaborations between the melanoma medical oncologist, which is, as you heard, we are close collaborators, and with the surgeons and everyone on the care team. And treatment is really personalized. We don't have a formula that we say, well, if you have this, then go to this, then go to this, then go to this, and this is what we do. We really get together as a group and decide for each individual what is the best approach. And treatments are evolving, so what we did even 5 years ago is not what we do now. So just to kind of give some perspective on what the challenge is, many of you know this personally or have read about this, but brain metastases as a whole, not just in melanoma, are very, very common because many of the common cancers metastasize to the brain. But melanoma accounts for about 10% of the overall brain metastasis population, which is a high percentage. And there's a fairly high risk of developing brain metastases for patients that have metastatic disease or even patients with advanced non-metastatic disease. So one question I'm often asked when I see patients is, how did they get to the brain? How did the cancer cells get to the brain? And what happens when they're in the brain? So this is kind of a diagram, a close-up view of the brain. And the brain tissue is this stuff here. And then this is the tumor, and this is a blood vessel. And so what you see is actually that the tumor cells come in through the blood vessels and land in the brain. They're not invading into the brain, and so they don't spread from one tumor to another tumor in the brain. They go from the blood vessel to the brain, and if there's another tumor in the brain, it also came from a different blood vessel to the brain. And that's important in the way we treat. This is very different than other tumors that form only in the brain and act completely differently. So how do we diagnose patients with melanoma brain metastases? Well, obviously if somebody is symptomatic, then it'll prompt a scan. But even asymptomatic patients that are at risk, we do a scan, and typically that is an MRI of the brain, and I'm sure many of you are familiar with that. And I thought I would introduce some terms that you may hear mentioned about and are not always explained. The first is the term enhancement, where we can see the tumor, and this is an example of an enhancing tumor with this white dot there. And that's because we use a dye that is white on the MRI, and tumors have leaky blood vessels. And so the dye leaks out into the tumor and looks white. In the normal brain, the dye doesn't leak out into the normal brain, so the normal brain has this grayish appearance. This is the next term called flare, and I won't try to explain what those initials stand for, but what you see here is a little swelling around the tumor. So the white on the flare is the swelling. So your doctor will often tell you there's enhancement and there's some flare abnormality, and this is sort of what it looks like in the brain. You have the tumor, this is a much bigger tumor, and you have inflammation causing this fluid around the brain, around the tumor, which is the flare. And that will push on the brain. One thing about the brain is it's contained inside a rigid structure, the skull. So in other parts of the body, a tumor can grow. You may not even feel it or detect it, but in the brain, it doesn't take much extra pushing to make it something that you notice, to increase the pressure inside the skull. So what are the symptoms? That's another question I'm often asked. How will I know if something's growing? And truthfully, there are often not any symptoms. The brain doesn't have any pain sensors. You feel no pain in the brain. In fact, neurosurgeons, again, I'm going to pretend to be a surgeon, can actually do surgeons on people who are awake. and they don't feel anything manipulated in their brain. But typically, increased pressure causes headaches, sometimes nausea, seizures sometimes, and so-called stroke-like symptoms, things that, say, a stroke patient may have, difficulty with movement, sensation, speech, or vision. But there is treatment, and treatment, as I said, is a team approach. It involves surgeons, radiation oncologists, and the medical oncologists working together, coordinating very tightly, very carefully. So I'm going to start with surgery with this somewhat, hopefully everybody's finished eating, picture. It turns out that brain metastases have been resected for a very long time, almost 100 years. The first reported case was in 1926. And it's useful when there are only a few tumors, 1, 2, 3, occasionally 4 tumors, all of which can be accessible, and all of which are located in an area that is not what we call eloquent. That is, an area where damaging the tissue around it might cause a severe neurologic dysfunction, like loss of speech or loss of movement. So if all the tumors are in areas that can be accessed and safe, then sometimes surgery is done even when there's more than one tumor. It has the advantage that it provides immediate relief. The pressure is gone, the tumor is out, the brain can recover. And sometimes we follow that with radiation. So here's an example. Here's a tumor here that was removed. Here's the tumor, and now you can see it's gone. Now in this case, there's still another tumor to go, and sometimes surgeries are not done all at once, but staged to allow the bone to heal between surgeries. So when do we resect? A single tumor, certainly, a few metastases sometimes, large tumors that have lots of swelling around them and are very symptomatic, a bleeding metastasis where the bleeding doesn't stop, and a metastasis that's been treated before, say with radiation, that continues to grow and needs to be removed. So that's pretty much all I'm going to say about surgery, so I don't get myself in trouble. And I'm going to now talk about radiation, which I think for many people, even people that have had radiation treatment, is still a bit of a mystery, how it works, why it works, and I'd like to help clarify some of that. So it still remains the mainstay of treatment for brain metastases. There are multiple approaches. There's the single treatment approach, what we call radiosurgery, because like a surgeon, it removes the tumor in one day, in one procedure. There's also the multiple treatment approach, which we call radiotherapy. So if there's 2 treatments or more, it's radiotherapy. And these, like I said, can be combined with surgery and sometimes with some drug therapies. And they can be delivered at times, even in patients that are severely sick, impaired. Radiation can be safely delivered because it's a minimally invasive procedure. So I have a few radiation physics slides. So if you felt like taking a little nap, this would be a good time. So what is radiation? And not everybody understands that. So radiation is actually, at least the kind we're talking about, energy from light waves. Now, there's lots of radiation, right? And I apologize, I stole this slide from Hong Kong, so there's some Chinese underneath, which I don't understand. But hopefully it says what's written in English on top. The radio waves that we listen to all the time, and our cell phones operate as well, clearly not dangerous. Microwaves, infrared, also not dangerous. These are the light waves that we can see with our eyes. Ultraviolet, of course, starts to get very dangerous, and we know about that. And then you have the X-ray and gamma ray radiation. Well, this diagram's a little bit off. So X-ray and gamma ray are the radiations that we use to treat, and they're what's called ionizing radiation, and they remove the little negative charge out of atoms. So that's what they do. An X-ray and a gamma ray are the same thing. A gamma ray is naturally occurring from a radioactive material, and an X-ray is man-made from a machine. That's the difference. How does it work? Well, now we're really getting specific here. People think that the radiation causes damage directly to the DNA, the genetic material of cells. In fact, what happens is it damages water surrounding DNA. And the water is broken apart into these very, very reactive but short-lived compounds that then break the DNA. And it's so-called double-stranded, where each of these ribbons is broken. And when they're broken, what happens is the DNA tries to heal itself, to stick back together, but it does a terrible job of it, particularly in cancer cells, which have turned off the repair mechanisms that normally exist in our tissues. And the reason they've done that is because repairing DNA takes time, and cancer cells want to divide quickly. So they turn off those mechanisms, and they do a terrible job repairing. And this is what chromosomes, which are large pieces of DNA in our cells, are supposed to look like, but instead they look like this funny structure, which when the cells try to divide, they can't, and then they die. And so that's how radiation kills the cells. But I tell you this because it's an important thing to know that after radiation, remnants of the killed cells may appear on an MRI for months or even years later. Until the cells try to divide, they don't die. However, when they're not dividing, they're also not causing any problem. So I often have to remind my patients, when we see the MRI, we see the little scar in the brain, that's okay. So standard radiation is given a little each day. It allows the normal tissues, the brain, to recover, and the cancer cells, as I said, recover less. Usually takes 2 to 3 weeks, and we only treat Monday through Friday. This is not to give the radiation oncologist time off. Everybody thinks it's not. It is to give the patient time off to recover from the radiation. This is the very common and very classic whole brain radiation. The white boxes are the areas that we block. So patients often ask me, will you be treating my face? This is the face, and no, we don't treat the face, the mouth, the throat, the nose are all blocked, and the front of the eyes are all blocked. But we do treat the entire brain with whole brain radiation. And so this is an example, and I've talked to you about some of the situations we use this. It can be used in emergency situations as well because it can be safely given even to patients that are feeling quite ill. So this is a kind of modified form of radiation that's given every day called intensity modulated radiation therapy. For anyone that's had radiation for melanoma outside the brain, this may have been the treatment that was used, and it allows us to shape and focus the radiation very, very carefully to bend around important structures in the brain. In this case, we're treating a tumor here, and we're bending around this structure outlined in black, which is the brain stem, the main conduit out of the brain. So it is possible to do that. So when we treat with brain radiation, there is a price. Like every other treatment, there is a cost, a toxicity. The most common is fatigue, and that usually occurs just after the radiation is done and can last for weeks, sometimes months. There's hair loss. There's changes to smell and taste, which are transient. They usually only occur shortly during or after radiation. There's sometimes some skin dryness, but we don't burn the skin. Sometimes there's not peeling and redness and a sunburn-like appearance. The thing that I think most people are concerned about are long-term changes, and those involve the cognition, the thinking of the brain, particularly memory. As these treatments, some of which you've just heard about so nicely from Dr. Hu have explained, people are doing a lot better. And as people do a lot better, we really have to be cognizant of what we're doing to the brain in the long term. So memory is, as I said, the most affected area of the brain. And what this is showing is all the different so-called domains of cognition in the brain. And what you can see is that even when there is a response to treatment, these gray bars, there is still a deficit in memory. Whereas in many of these other domains, when there's a response to treatment, there's even an improvement in those other domains, but not true with memory after radiation. So what's the reason we focus on this? Of course, brain metastases and radiation impact cognition. That's in fact what this graph is showing. These are tumors growing. They impact cognition, in this case, more than memory. So we limit whole brain radiation in situations where we think the risk of the metastases to cognition is far greater than the risk of the radiation. So it's a balancing act. The other thing to remember is that the appearance on the MRI, and I talked about this after treatment, the scarring, is not the most important thing. The most important thing is how you're doing, how you're able to function. So we don't want to focus too much on, well, yeah, the treatment shrunk the tumor, but you're not feeling any better. That's not helpful. So cognition gives us an objective way to measure how people are feeling, not just looking at a scan. So IMRT, which I showed you about a few minutes ago, can actually improve whole brain radiation. And this is a clinical trial that was completed a couple of years ago and is now moving on to the randomized trial setting, where these areas of the brain circled with these concentric circles called the hippocampus, which is involved in memory and learning, is being intentionally avoided with whole brain radiation to preserve memory. And in the early preliminary trial that was done, this did an excellent job of preserving memory, and so is now being, as I said, explored in the randomized trial setting. Another approach is to use a memory preservation drug that's actually borrowed from the Alzheimer's treatment community. And the reason that's important is because drugs that treat Alzheimer's have to be able to get into the brain. And so this drug we know gets into the brain, and it's called memantine, or the brand name is Namenda, and it prevents neurocognitive damage. And this was a clinical trial that was reported back in 2013, which showed that giving this with whole brain radiation preserved memory. And in fact, this is our standard now to give this drug. But when we don't do whole brain radiation, we do focused radiation, and that's this radiation called stereotactic radiosurgery, sometimes abbreviated SRS, sometimes just called radiosurgery, so keep all those names in mind, and sometimes called by the machine brand that we use to treat, which we probably shouldn't do, but that's what we do. So patients are treated as an outpatient. You're not in the hospital for this. All the radiation is given in a single day session. There's less, or if any, impact on neurocognition. There's really no evidence that there's a neurocognitive impact. It often requires placement of what's called a stereotactic frame, which I'll show you in a moment, which isn't a huge deal, but for some people, when they see the picture of it, they think it is, but people do very well with that. And this is a treatment that's actually not new. It goes back to 1949, when a Swedish neurosurgeon, but now I'm allowed to pretend I'm a neurosurgeon in this case, named Lars Leksell, invented the first stereotactic radiosurgery. And various machines and devices have been developed to improve on that. Lars Leksell's son, Lars Jr., I guess, I'm not sure his name actually, still works for the company and still advises the company that makes stereotactic radiosurgery instruments called the Gamma Knife. But there are many types of devices. There's something called the Brain Lab by Novalis. There's CyberKnife. There's standard radiation treatment machines that use a very high-tech imaging method called ExactTrack. There's standard radiation machine attachments that you attach to the top of the machine called the X-Knife. The standard machine we use is called a linear accelerator, or a LINAC. The CyberKnife here, this is a robotic arm that can aim radiation beams from all different directions. This is borrowed from, you might have guessed, the automotive industry, actually. Here at MD Anderson, we use this machine called the Gamma Knife. This is the most current version called the Perfection Gamma Knife. And what you see here is a patient lying down, the head in the machine has been cut away, so you're seeing it sort of from the innards, which you don't see. It's just a white box inside. And 192 tiny beams of radiation are all centered on a single point in space. And the idea is to move the patient, not the point, so that the tumor is at the point. And so we can do this. Here's the beam coming on, and then we move the patient, and then we apply the beam again. And this allows us to treat many tumors very, very precisely in a very rapid time. We actually also use the same stereotactic type treatments to treat the spine. So for people that develop metastases to the spine, we can use IMRT combined with stereotactic treatments to treat just the area of the tumor and not treat, this is the conventional way to treat the spine, where you pass beams through the entire abdomen. So all of this, which is the intestine, is getting treated, where in this case, only the spine is treated. So how do we decide between whole brain radiation and radiosurgery? Well, before 2010, the standard across the world was for patients that had more than 3 brain metastases, with the exception of Japan, where it was more than 4, where everybody was given whole brain radiation. Radiosurgery was used if there were new or progressive metastases after whole brain radiation was done at some point in the past. Patients with 3 or fewer tumors were given whole brain radiation followed by radiosurgery, so they were given both. And there was a randomized trial to support that. However, since 2010, There have been several clinical trials, one done here at MD Anderson in 2010, and then another one reported just this year in June at the big oncology meeting in Chicago. Both reinforce the idea of giving radiosurgery alone to people with 3 or fewer metastases, and doing so had a dramatic improvement on neurocognition. So what about patients with more than 3 metastases? Over the past few years, there's been an increasing preference for radiosurgery. New treatment technologies, such as the latest version of the Gamma Knife that we use, have allowed for very large numbers of tumors to be treated in the same session. But I should emphasize that there is no clinical trial data or no randomized clinical trial data to date that supports using radiosurgery for more than 3 metastases. Yet it remains a balance. We're trying to protect cognition. We want to get adequate tumor control on the one hand, but we also don't want to cause too much radiation damage. Whether we can do that with one modality or the other or the two combined is something we don't know. So every case is evaluated individually and a decision is made based on that. So we can combine treatments. I've already told you about combining radiation treatments, radiosurgery and whole brain radiation. The order doesn't matter. We can give whole brain radiation first. We can give radiosurgery first. We can give radiosurgery after whole brain radiation. And that is very typical. Is there a water? Drugs can also be given sometimes with radiation. Thank you, Dr. Davis. There is a drug called temozolomide, which is sometimes used in the treatment outside the brain, and it is also used for treating brain tumors that occur in the brain only, not melanoma. So we know it gets into the brain, and that drug can be combined with whole brain radiation. The effect of this is unclear, but it can be done safely. With radiosurgery, almost any drug can be given at the same time. So we don't need to stop drug therapy, chemotherapy or targeted therapy or immunotherapy that is going on for other places in the body in order to give radiosurgery. Thank you. I'll tip you later. Okay. So what about drugs alone in treating the brain? Well, many have little or no effect in the brain because of something called the blood-brain barrier. So this is the brain, and you can see a blood vessel here, and you can see we've zoomed in on this blood vessel, and what you see is that these blue cells are the lining cells of the blood vessels of the brain, and they stop most molecules from getting into the brain. And you might ask, well, why did they do this? Why is that the way humans developed? And I always tell people it's to protect us from the poison berries. When we're wandering around in the early days of humanity and we're picking things, we don't want our brain to be affected. We may start throwing up from the poison berry, but we don't want our brain to be affected. And that's why that developed. But as a consequence, it also protects the brain from things we don't want it to protect it from, which is the important drug therapies that are being delivered. Some small molecules get through, like temozolomide, but many don't. Many antibodies don't get through. However, there have been some very recent studies that have shown that some of the most promising drugs that you've heard about and we'll hear more about today actually have a response to brain metastases. So the mutant BRAF inhibitors, like dabrafenib and vemurafenib, certainly dabrafenib has been shown in a clinical trial to have a response in the brain with no radiation given. Immunotherapies that you just heard about activate the immune system, and whether or not the drug itself gets into the brain may not be as important because the immune system does get into the brain. So if you activate the immune system, it may be enough to have an effect, and in fact, the earlier trial with ipilimumab showed that there was a response in the brain. Giving anti-inflammatory drugs, which we often give for swelling in the brain, however, diminish that response. There's this concept called the Abscopal effect. And the Abscopal effect is a great word to throw around at dinner parties. And what it is this idea that if we treat one part of the body with a tumor, that the immune system will be primed and will now attack the tumor somewhere else in the body. And in radiation oncology, we're very excited about this, and immunotherapy. So we can treat one part of the body, expose the dead tumor cells, abnormal proteins to the immune system. The immune system is primed with one of these great drugs you've heard about, and then attacks the cancer somewhere else. This is an example in the lung, where the lung was treated right here, and you can see the lung responded very well, but then other areas here in the liver also disappeared, even so they weren't treated with radiation. And this we're hoping is true in the brain, and that's an active area of investigation. So what if radiation fails? There's always surgery still. So if the area is accessible for surgery, same rules apply. It can be removed. And more recently, there's been an interest by the surgeons in something called thermal ablation. And there are a couple of systems that do this. But this is a much less invasive procedure than brain surgery. But it involves sticking a small catheter into the tumor and heating it up. And they actually do that under image guidance. So they do this in the operating room where there's an MRI present. And they can actually see the area that they're heating up and destroy the tumor. And this is a very effective, what we call salvage therapy. And we're doing this a lot now. So to kind of summarize, again, I'll emphasize that treatment is multidisciplinary. Surgery and radiation still are the primary approaches. Radiosurgery is minimally invasive and is very, very good for when there are multiple tumors. Whole brain radiation is being optimized to minimize the things that most of us are concerned about, this neurocognitive change. Radiosurgery in the context of many metastases, whatever that cutoff is still being explored and is taken on a case-by-case basis. And new drugs like the mutant BRAF inhibitors and the immunotherapy are really very vital adjuncts to treating brain metastases. So I want to thank you, and I think we'll have an opportunity at the end for questions.